Welcome everyone to this month's discussion on an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap. I'm one of the gastroenterologists here at Mayo Clinic in Rochester, Minnesota. It is my great pleasure to welcome my colleague, Dr. Michael Camilleri. You really needs no introduction. Dr. Camilleri is a consultant in the Division of Gastroenterology and Hepatology at Mayo Clinic in Rochester, Minnesota, and is also the professor of medicine, pharmacology, and physiology at the Mayo Clinic College of Medicine. He's past editor of this journal, Neurogastroenterology and Motility, and he's also the past president of the American Neurogastroenterology and Motility Society, as well as the American Gastroenterology Association Society. He's published over 480 peer-reviewed manuscripts, and his work has been supported by multiple grants, not only from NIH, but also from other sources. Dr. Camilleri has really contributed a lot to our field. He has developed and validated clinical diagnostic tests that enhance the practice of neurogastroenterology, including scintigraphic pan-gastrointestinal transit, SPECT for gastric accommodation, colonic tone and sensation by barostat, and fecal bile acid measurements. These are just to name a few. He's also examined the mechanism of action and efficacy, or the lack thereof, of virtually every drug introduced in the field of functional gastrointestinal disorder over the past quarter of a century. So we're very fortunate that he's provided a commentary on the comprehensive recommendations on gastroparesis from European Society of Neurogastroenterology and Motility and the United European Gastroenterology Federation sister societies, which is published in the current issue of Neurogastroenterology and Motility Journal. He joins us today to discuss these recommendations as well as provide the additional insights that are included in his commentary. Welcome, Dr. Camilleri, and thank you for taking the time to join us for this discussion.
Thank you. Thank you for having me.
Sure. Specifics, Dr. Camilleri, I wanted to start by getting your perspective on the field in general, as you've seen it evolve over the past half a century. So how do you think we've fared over the past few decades when it comes to making sense of gastroparesis?
Thanks, Purna. I think there have been some pretty significant advances, not only at the level of the sort of basic science with cellular, molecular, and other insights being obtained through studies of full thickness biopsies, but also I think in the context of the presentation, the clinical presentation, the diagnosis, and as we shall discuss, also some of the therapeutic strategies that have been introduced. We aren't quite there yet. Certainly in the United States, we have no new drugs approved by the FDA for several decades. But I do believe that we are on the course to having more to offer for our patients. And we have this document as well helping us to have a clearer understanding of the natural history, the epidemiology perhaps, and also the diagnosis and treatment of patients with gastroparesis. So I'm optimistic that we are on the right track.
Great, that's really good to hear. And I think we all realize that progress is slow, but as we go, we learn new things. So let's start by then discussing the process of these recommendations. Can you just tell our listeners briefly of how consensus statements are developed and what is the process behind them, so they understand that this is no small task?
Yeah, indeed, this is no small task. And as you introduce it, it did involve several sister societies, mostly in Europe, as well as the European Society for Neurogastroenterology and Motility. And they went through the process of a Delphi approach in which proposals are discussed, recommendations based on an overall vote by the participants, by the experts, are then taken in order to try to come up with a summary of the current state of the art. And of course, those votes are often based on the highest level of evidence that's available. Those are usually original studies, randomized controlled studies, systematic reviews and meta-analyses, and also subsequently, in many of these guidelines or these consensus statements, there is the additional discipline of grade methodology to determine what is the level of potential bias, what is the level of strengths of the evidence that's provided in the particular studies. So in the few minutes that we have available, it's very difficult to go through this in more detail, but certainly the original article published from the European groups detail all of the additional approaches and precautions that were taken to come up with the recommendations and statements.
Absolutely. And, again, I think we'll obviously encourage our listeners to read the article to understand that this is really a complex process. But I just wanted to highlight the rigor by which these are developed so people can feel confident in terms of implementing these recommendations. Now that we understand the process, let's talk about the recommendations that themselves, which come from this process. In your opinion, what are the current disagreements and where do we have consensus when it comes to defining gastroparesis and the symptom descriptors of gastroparesis, especially things like pain, and how does this eventually affect the epidemiology considerations?
So, I mean, the first really important point to make is that my colleagues and I, and incidentally, I want to give credit to the co-authors, Samdil Magani, Kia Vasugi, and Johnny Zeng, who are currently fellows working in my laboratory, but we all went through the discipline of doing a thorough review of the literature, as well as study the consensus or recommendations provided by the European group. So that's the first point to be made. The second really important point is that we agreed with many of the recommendations based on our study of the literature. And what we tried to do in our commentary is to provide additional insights that perhaps were not quite available or published at the time when the Delphi process or the discussions had been conducted. And so we kind of updated literature, particularly from 2019 to 2021, on several of the issues where there was perhaps an opportunity to enhance our current state of knowledge. So let's think a little bit about some of the points that you mentioned. First of all, the issue of pain. So yes, indeed, the recommendation here, number 2.2, was that the symptoms of gastroparesis were mostly consistent with postprandial distress syndrome of functional dyspepsia. And that is absolutely true, rather than epigastric pain syndrome, which is another subtype of functional dyspepsia. But since the study, this paper was written, the commentary was written, there was actually a paper from the United States that showed that even though it's not the predominant symptom, pain is a frequent component of the symptoms of patients with gastroparesis. So we wanted to remind readers that the presence of pain does not exclude the diagnosis of gastroparesis, but yes, the predominance of symptoms should not be pain itself. So that's one of the points that we thought was important to bring greater clarity on. The second was the very difficult question of epidemiology, and there have been a number of attempts to define the epidemiology of gastroparesis. Some of these are based on very large electronic health records in the United States on several hundred hospitals. There is also an epidemiological study now that's just come out in the last 6 to 8 months from the United Kingdom based on general practice databases. And so the actual details on the epidemiology vary from one study to the other. And indeed, there was a very famous study done actually by our colleagues here at Mayo Clinic, headed by Nick Talley when he was here, based on nuclear medicine gastric emptying studies of people living in the community in Olmsted County. So I've just illustrated to you 3 different standards that have been used: electronic health record for hospital system, electronic or databases from general practice in the United Kingdom, and third, in Olmsted County, Minnesota, which is perhaps has the advantage of having easier access to a robust gastric emptying test, the data on epidemiology are different. And so we have to keep in mind that anytime we're doing any assessment of epidemiology, we have to really understand what is the basis for the diagnosis. So I still am not so clear in my own mind what is the prevalence of gastroparesis. And I think in the future, more studies need to incorporate the gold standard for the diagnosis of gastroparesis if we're going to make better insights on on understanding the epidemiology of gastroparesis. And from there, of course, that's essential if we're going to be able to study the natural history. And in fact, in the conclusion of our commentary, we say that this is one of the things that needs to be a focus for the future. So I know that's a long answer to your question, but in summary, I think that the pain and the epidemiology and the gastric emptying are three very significant components that require further study.
Thanks, Akami. And I think the long answer is warranted here because there is a lot of, like you said, there's lack of clarity in this, and we'll probably come back to the end of this at the end of the conversation to talk about gastric emptying and how it incorporates into epidemiology if we can't get the symptom correlation with that. But moving on to the next aspect, because the epidemiology is important because it defines what the impact of gastroparesis is on a population level. But when we talk about gastroparesis at an individual level, affecting their quality of life or health as measured by life expectancy or work productivity or weight gain or weight loss, what are your thoughts on that based on these recommendations?
Yeah, so again, there are some data, and I'd like to again refer back to some of the studies I just enunciated. So in the Olmsted County, Minnesota study that was done more than a decade ago now, there was evidence that patients with gastroparesis actually did have a reduced life expectancy, which would be sort of contrary to the conclusion reached by our colleagues in Europe regarding the effect on life expectancy. Secondly, the recent study by Ye and colleagues from the United Kingdom epidemiology study did not actually compare gastroparesis to non-gastroparetics in the population, but they did show that patients with diabetic gastroparesis have a worse life expectancy than patients with idiopathic gastroparesis. And that's based on a very large patient sample population. I mean, it included about 7 million case records that are available in the United Kingdom database.
Yeah, so and again, I think this comes back to a lot of it would, if the way the epidemiology is defined, I think that's where a lot of these factors in terms of impact would also be defined. So we're bound to see some differences in geography based on how the disease was defined. But given that both of these are continents where we have almost equal access to healthcare, do you think that these differences might be because of individual population characteristics or because of more of the epidemiological characteristics or underlying diseases which might be contributing to the morbidity? So
it's a great question, Perna. When I look at the data from most countries, you come down to there still being only three main categories or dominating categories of gastroparesis: idiopathic, diabetic, and post-surgical. And in that respect, I don't think that there were differences in the databases from a localized Olmsted County population versus the United Kingdom larger database. I think what is different, however, is the diagnosis of gastroparesis, because in the vast majority of studies, gastric emptying has not been measured. And so if we're going to consider that the presence of delayed gastric emptying is one of the important major criteria for the definition of gastroparesis, we have to keep in mind that not all epidemiological studies have been able to include that as an inclusion criterion. So there still is some room for certainly investigation, but it also begs the question as to how do we make the diagnosis of gastroparesis? And I know this is something that perhaps we will be discussing in the next few minutes.
Absolutely. I was going to take a break from the epidemiology and the impact on individual health and talk briefly about pathophysiology, because that's also been a tough challenge in this field, starting all the way from the role of gastric neuromuscular apparatus and interstitial cells of Cajal in determining gastric emptying, to now considering the newer roles of immune cells, changes in duodenal physiology. So based on your read of the consensus statement and your additional insights, where do you think we are with this? Because that becomes an important component of all the previous things that we talked about. And where do you think we need to go with this?
So, the European consensus statement made it pretty clear that at the present time, there is insufficient data to really endorse either smooth muscle or inflammatory or immune cells, or indeed interstitial cells of Cajal, or other pacemaker cells by like the platelet-derived growth factor receptor alpha cells, which are fibroblast-like cells which act like pacemakers. So at the present time, the European group felt that there wasn't sufficient evidence to endorse these as pathophysiological or etiological mechanisms for gastroparesis. And I think it points to the need to continue to do research in these areas. The data have been acquired predominantly by studies done here in the United States by the NIH Gastroparesis Consortium, and they are based on full thickness biopsies taken from the stomach. And I think this is providing some very important new insights on mechanisms, and it may actually provide ways in which to fashion new approaches, which may be targeting specific types of macrophages or inflammatory cells that are thought to be involved in the oxidative stress, if you wish, the oxidative damage to the nerve cells and the pacemaker cells in the stomach. So to summarize this information, there is evidence that there is reduced number of interstitial cells of Cajal, pacemaker cells, but there's also evidence of some reductions in some of the excitatory and inhibitory neurons, like cholinergic neurons, excitatory and inhibitory neurons being nitroergic neurons. And these don't just affect the muscle layer of the stomach, but also of the pylorus. And so, going forward, I think that further objective information obtained from biopsies nowadays with GPOEM revolution, there may also be opportunities for obtaining biopsies from the pylorus at the time of pyloromyotomy in order to determine whether these mechanisms are important. And perhaps the next generation of recommendations will have sufficient data for European, North American, and other groups of neurogastroenterology and motility experts to endorse the importance of histopathological assessment in these patients. And hopefully that will give further insights as to how best to treat the patient.
Great, and that's an important point, which highlights the complexity of this disease and highlights the need for continued investment in trying to understand the pathophysiology if we hope to develop newer mechanism-based treatment approaches. And I think in that regard, NIH took a good approach of establishing a consortia to try to promote this, but I think we need a lot more in terms of investment to understand this. Now coming to the contentious question of what are the recommendations for making a diagnosis of gastroparesis? As you just alluded to, by definition, it means delayed gastric emptying. So is gastric emptying test needed? If so, what is the optimal gastric emptying test? And as you mentioned, that's the test which is needed to make the diagnosis, but often it may not correlate with symptoms. So do we still consider the optimal test, or do we need things for tests of vagal function or other aspects of our physiology?
So I do think that the American College of Gastroenterology guideline of 2013 made three important factors in the diagnosis of gastroparesis. Number one is the presence of symptoms consistent with delayed gastric emptying: nausea, fullness, bloating, postprandial sensations, sometimes pain, sometimes vomiting. That's the first prerequisite. Number two, the absence of mechanical obstruction, either at the level of the stomach, the pylorus in particular, or in the upper gastrointestinal tract. Number three, evidence of delayed gastric emptying. But of course, we have to keep in mind that the evidence has to be based on a robust or optimal gastric emptying test. So to cut a long story short, it is important to do a gastric emptying test that assesses the emptying of solids, not liquids, not homogenized solids, not liquid nutrients, not oatmeal, not etc. So make sure that this is involving a solid substrate. Secondly, it's been shown that optimal assessment of gastric emptying requires an assessment for at least 3 hours after the ingestion of the meal, ideally 4 hours. Now, there are two approaches in the United States that have been validated and have been approved for measurement of gastric emptying. One is, and these are also the recommendations that came from a consensus statement by the Society of Nuclear Medicine and the American Neurogastroenterology and Motility Society. So number one is still considered the gold standard, and that is scintigraphic gastric emptying of solids. Second approach, which is approved by the FDA, is a stable isotope breath test based on 13-carbon spirulina. That involves also the emptying of solids from the stomach and the appearance of 13-carbon CO2 in the breath. So if you use those types of optimal gastric emptying tests, it's important to realize in a systematic review and meta-analysis that there actually is a significant relationship between symptoms and delay in gastric emptying. And the main symptom, the most convincing data, is for the symptom of nausea. And let's face it, in most patients with gastroparesis, that is the dominant symptom. So if you have a patient in whom you're suspecting gastroparesis who has significant nausea, definitely a gastric emptying test is going to help you evaluate that patient's symptoms. So that's the first point. The second point I will make is that if you do an optimal gastric emptying test, then you will find that there is a relationship between improvement in gastric emptying T-half and improvement in gastric emptying symptoms. And this was based on another paper that was published in Gastroenterology. Now, I mentioned these 2 points because these were points where we actually disagreed with our friends and colleagues in the European studies, because we actually saw in papers that were published in 2019 and 2020, the relationship, the significant relationship between symptoms and optimally measured gastric emptying, and the relationship between improvement in symptoms and improvement in gastric emptying T-half in response to a prokinetic approach to treatment. So to cut a long story short, there is a significant improvement in symptoms that is clinically demonstrable with a change in gastric emptying T-half of 20.4 minutes. So if your patient has a gastric emptying T-half of 150 minutes and it comes down to 125 minutes, that is usually associated with an improvement in symptoms that your patient is going to experience. So I do think that gastric emptying still is a very important component to the assessment of patients with gastroparesis, with suspected gastroparesis. But of course, you have to do it the right way. Otherwise, you don't have the sensitivity or the specificity that you need for your diagnostic and for your therapeutic practice.
Thank you so much for stating that so clearly, and stating that it's not just doing the test, but also doing it in the optimal manner, and also highlighting that it's some of the recent data which came after the evidence for this ESNM recommendations had come out that showed that improvement in gastric emptying can also improve symptoms. So that's why it's important to know that new data is coming in this field, and so these recommendations evolve and change over time, and that's why we do these periodically. And obviously, our goal is to try to bring the most up-to-date evidence to our readers as well as listeners. Then coming obviously to one of the most important aspects, which is the treatment of gastroparesis, because that's what people want to know, how do I treat this? And we often have to treat conditions when we don't fully understand the pathophysiology, but we can't just sit back and wait for that to happen. So it can be a challenge, but just like you mentioned, it could also be a learning process. Like with GPOM, if you're able to get biopsies, we may be able to learn more as we develop these treatments. So we know that prokinetic medications which accelerate gastric emptying have been considered the mainstay, and you just highlighted how improving gastric emptying may improve symptoms in patients. So what are the recommendations regarding the available treatment options, including prokinetics?
So I would say at the present time that there are four main points to be considered. The first is, let's remember the wonderful paper by Olafsson and Magnus Simron and colleagues from Gothenburg showing that a small particle diet improves in a randomized controlled trial versus normal sized dietary components. The diet is important. Blenderizing the diet, low fat, low fiber are still very important. And the nice thing, as we said, is that our colleagues in Sweden have actually done a randomized controlled trial of that. Secondly, symptomatic treatment with antiemetics is certainly something that we all will use, and it does provide relief to symptoms. But the mainstay for reversing, in our current state of knowledge, reversing the pathophysiology, reversing the antral hypomotility that is thought to cause the delay in gastric emptying, is to use a prokinetic approach. And we've just enunciated the recent evidence of the relationship between prokinetics, improved gastric emptying with an optimal gastric emptying test, and the improvement in symptoms. But the new kid on the block, which is really very exciting, and it's being applied in many, many different countries, and certainly several large studies from Europe and now also from the United States, is the possibility of doing a pyloromyotomy during endoscopy. So gastric per oral endoscopic myotomy, there are multiple studies now. In fact, there are many systematic reviews and meta-analyses of those studies already published. And I'm going to try to summarize. Virtually all of the studies show a benefit of GPOM compared to the situation of symptoms and gastric emptying before the GPOM was performed. The second point I will make is that research is suggesting that understanding the diameter and the distensibility of the pylorus can be a predictor of responsiveness to treatment. And several groups have studied this, including Nascle and his group in the Netherlands, including Gourcerol and his groups in France, and also our colleagues at University of Michigan, Watts, Hasler, and colleagues. So all of these groups seem to be suggesting that, and of course the group at Johns Hopkins, I mustn't forget Dr. Kashev and his group. So the point is that there are several bits of information that suggest that intervening at the level of the pylorus could actually enhance the patient's symptoms and gastric emptying after the procedure. What is lacking? What is lacking is really an understanding of mechanisms for why the pylorus is not working. And secondly, what is lacking is a sham controlled study. And so I think this is a direction that needs to be taken in order to place GPOM on a stronger footing. And I must remind us that there are many, many groups that have really contributed very important data. I forgot to mention the group at Emory in Atlanta, also in the United States, and there are probably several other groups that I'm forgetting from Europe and other parts of the world. So this is a very exciting area. I do think that the opportunity to get biopsies at the time of the GPOM might give us some insights, particularly on nitrogen neurons, because they are very important for the relaxation of the pylorus. And so if the diameter is small, if the distensibility is small, is it because the relaxation induced by inhibitory neurons is deficient in those patients? So I think this is an area where we should see further advances in the future. And we think this is a very exciting area of investigation.
That's great. And, it's always nice to leave on an optimistic note, knowing that there's not only treatments available, but there is optimism for newer therapies, which are likely to be more effective and also improve our understanding of the pathophysiology. With that, I just wanted to give you a chance, Dr. Camilleri, if you missed something that you wanted to share with our listeners, we'd be happy to talk about that.
So I'll just make one final point, and that is that in addition to the GPOM, it is possible that the combination of a prokinetic plus GPOM may actually enhance the outcome for the patient. And we certainly see that as an opportunity in patients in whom gastroduodenum manometry actually shows evidence of anterior hypomotility in addition to the results which are being obtained with impedance measurement at the level of the pylorus, which show abnormalities of the pylorus. So we see a future where we can be much more specific and individualized treatment if we can really understand how is the pylorus functioning, how is the lower part of the stomach functioning, and is there really objective evidence of delayed gastric emptying. I think we are going to, need to put back on our physiology hats, our mechanistic hats in order to be able to advance the field and produce better outcomes for our patients. But again, I want to tip my hats to our colleagues in the European Society of Neurogastroenterology and Motility and the sister societies of gastroenterology in Europe for the outstanding work they did in summarizing and bringing forward their recommendations. And I also want to reiterate that for most of the recommendations, we agreed with their assessment of the current state of the art. And our objective in our commentary was simply to try to enhance on the information based on perhaps newer papers that had not been considered during the Delphi process. So thank you again.
Thank you so much, Dr. Camilleri. And again, I want to echo your comment about thanking the European Society as well as the sister gastroenterology societies, as well as your effort to try to provide additional insights. And again, your time today to discuss this important topic. And I also want to thank our listeners for joining us for this interesting and important discussion. And I would encourage them to take this opportunity to raise awareness about gastroparesis in the general population. Thank you.
Thank you.